Hi everyone. Hi everyone. Am I audible to all? Yeah. So welcome back. Welcome back. Just let me check whether it's on the online. Yeah, yeah. It's great to see. It's great to see. It's great to see. Yes. So I hope you all are doing fine. So today the topic of discussion is that we'll discuss a basic approach to abdominal trauma. I hope you must have seen that case of acute cholecystitis that I discussed 2 days back. So today I will be discussing a comprehensive approach to abdominal trauma. Comprehensive approach to abdominal trauma. Just wait. Just let me do some realignments. Yes, and then we can start. Yeah. Okay. Now, before I start with, let me introduce myself. Many of you might be seeing me for the first time. My name is Dr. Saurabh Dixit, and I'm a practicing laparoscopic surgeon from New Delhi, and also an educator at Unacademy platform. You're educated for surgery. So, before starting this lecture, I would just tell you some. I'll just brief you about the things which are going in Unacademy for students. We have a daily free test series, and that is really a very helpful exercise. I'm very thankful to Unacademy people that they are so innovative and they have been planning all these things. 20 questions, 20 minutes. Yes, and you can to lock. This is free for all. You can use my code surgery live on YouTube platform. My code is surgery live, and for plus platform the code is different. So surgery live platform to unlock this for free, and then I'll just tell you about the beautiful batch which has started, and that's the last mile. The last mile if we talk about is a batch that has started recently, and this is a revision class which we are planning to target the NEET PG 2021 session. So you still have time, you still have a lot of time to revise. And again, please don't miss this combat session. This time on 24th we have a combat where you will have 45 questions. This is not only rewarding, but actually rewards are the byproduct. The most important thing is you to keep in rhythm and tone. 45 questions from pharma, pathology, FMT and anesthesiology. Do test your skills, not to get award, but rather to boost your morale. So use this code surgery live to unlock this free plan. So now let us start with the concept based approach to abdominal trauma. Yeah, abdominal trauma is a very important topic. Trauma, in fact, is the most important topic of all. It's the most important topic as far as surgery is concerned. Last to last session of AIMS, you had 8 questions straightforward from trauma. So, topic of discussion today is abdominal trauma. When we talk about abdominal trauma, today I'll clear lot of confusions that you people often have. So, when we talk about abdominal trauma, one very important thing is that how to approach this abdominal trauma. How to approach this abdominal trauma. Yes or no? Yeah. Now, when we talk about abdominal trauma, the first piece of information that we want from the patient is what is the nature of trauma, whether it is penetrating or whether it is a blunt trauma. So approach, the first thing that you will ask is what type of trauma it is, whether it is a case of penetrating trauma, whether it is a case of penetrating trauma, or whether it is a case of blunt trauma. So penetrating versus blunt trauma. Now, if it is a case of penetrating trauma, you have very less time because time is running out from your hands because you may lose this patient. So what is important here? Then you need to assess the status. What is the status? Yes or no? What is the status of the patient? Students, patient could be either unstable or the patient could be stable. Patient could be either unstable or the patient could be stable. If the patient is unstable, you directly have to go for surgery. You don't have to waste your time here. You directly have to go for surgery. Now tell me, what surgery are you going to do? What surgery are you going to do? Tell me. Yes, you're going to explode the abdomen because you don't know what you're going to do. You're going to open the abdomen. So opening something is known as stomy. An abdomen, yes, the Latin word is laparo. So you are going to do a exploratory laparotomy. You are going to do exploratory laparotomy. Is that clear to everyone? Exploratory laparotomy. Now, if the patient is stable, if the patient is hemodynamically stable, what to do now? If the patient is hemodynamically stable, you can send that patient for CECT. CECT. CT scan is the investigation of choice for stable patients. Now, try to understand one again very important things. There are few conditions where the decision making is totally different. Yes or no? So you should know stable penetrating, or let us write penetrating injuries, penetrating injuries with any of them. With any of them. What is any of them? What are these any of them? Yes, if you get a patient with gunshot injury, if you get a patient with gunshot injury, yes, if you get a patient with evisceration, viscera protruding out, yes or no? If you get a patient with impaled object, like weapon is still there in the abdomen, someone is stabbed with knife and that knife is still there. So impaled object, yes. Now, why is this impaled object important? Yeah, I'll tell you each and everything, just wait. And then bleeding via natural orifice. So penetrating injury with bleeding via natural orifice. Now suppose a patient has been admitted with penetrating injury. Someone is stabbed on the abdominal wall and patient is having bleeding PR. Students, this bleeding PR is not possible until and unless the GI tract integrity has been breached. So patient is stable just now, but do you know very soon this patient will develop peritonitis. First because of hemoperitoneum and then because of the feculent material, and that will be known as feculent peritonitis. Do you know the chances of survival in case of fecal peritonitis is less than 10 to 20%. Less than 10 to 20% survive, else you lose the patient. So do you know any surgery done with an intention to safeguard life is always justifiable. So these are the conditions where irrespective of the status, irrespective of the status, you plan a what? Surgery. Is that clear or no? So irrespective of the status, you plan a surgery. This is very, 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 very important. Now, impaled object, if you talk about, suppose, try to understand, there is a patient, yes, there is a patient who has a weapon, yes, who has a weapon impaled into it. Yes, let me show you a weapon impaled into it. Let me show you a weapon which has been impaled. Yeah. Now you try to show mercy and you take out that weapon. Do you know every weapon is associated with some level of injury? It may be having a concealed injury. The moment you remove that, the weapon which was acting like a tamponade now, the tamponade is released and now you will have gush of bleeding. Now this bleeding will cause hemoperitoneum, which will cause the scenario. The patient will decompensate and will die. Remember, any type of impaled object, you should take this patient to OT. And what do you do here? Under the local or maybe you should induce the proper general anesthesia, and then you should do a liberal midline incision, and you should take out the weapon and also evaluate for or look for the other site of potential injuries. Is that clear to everyone? Why in case of gunshot, why in case of evisceration, why in case of impaled object, why in case of bleeding orifice, surgery is given priority. Is that clear or no? So now let us talk about a patient who presents to us with blunt trauma. A patient who presents to us with blunt trauma, the next thing that you need to ask is again the same question. What is that? Stable versus unstable. Stable versus unstable. Yes, stable versus unstable. If the patient is stable, you don't have any other choice. You go for CT scan. Now, there are students who ask, sir, why we can't do CT for unstable patient? That is why most of the time I say, bache or students, because you really are kids. You have not gone to ward, and that is why you keep on fantasizing the medical scenario. Now, CT cannot be done bedside. You cannot get that big CT machine onto the bed. Stable patients can be transported to the radiology department. But unstable patient, you are resuscitating. Unstable means hemodynamically unstable patient. You are transfusing blood, you are giving lot many things, you are trying to stabilize the patient. How can you disconnect them and insert the patient inside a CT machine? Is that clear? So the moral or the dictum is that in unstable patients, we always tend to do any procedure that should be what? Bedside. Is that clear? So we do the bedside procedures here. Is that clear or no? We do bedside procedures. Am I clear? So stable patients, you go for CCT. Unstable patients, now what to do? Unstable penetrating trauma, you just jumped into what? Okay, I will do a surgery. But unstable blunt trauma, unstable penetrating trauma, you went for surgery. When you talk about unstable blunt trauma, now you are thinking, shall I go for surgery or shall I continue the conservative management? Yes or no? So who will tell you whether you should go for surgery or whether you should go for conservative management? Can you people tell? Audience, to you, please tell me what should be the next call. What should be the next call in this case? Yes, can you tell me this? Come on. So if you have a patient who is unstable and you want to decide whether to go for surgery or no, something from F, and yes, that is what is known as FAST. Yes, FAST. Now, FAST is a quick radiological assessment of the 3 peritoneal compartments or peritoneal pouches. Yes or no? So FAST, if the FAST is positive, you plan a surgery. If the FAST is negative, what to do? There could be two things. Either there is no significant injury or you have done the FAST too early. Yes or no? So you can do a repeat FAST in this case. Now, there are many institutions, many people who say that you should be going for DPL. DPL is obsolete nowadays. You should not even utter the name of DPL until and unless someone asks you, do you know DPL? You'll say, yes, my grandfather used to practice this DPL. But in this era, the radiological support is so good. Yes, we don't use DPLs. We use FAST. So repeat FAST is what we do. Now the question is, when will you go for this repeat FAST? This is done after 30 to 45 minutes. 30 to 45 minutes, we start with repeat FAST. Now if repeat FAST is positive, you go for surgery. If repeat FAST is negative, you go for what? Now do you know, you people, arbitrary, I have seen people teaching also, I've seen followers following also. Investigation, first line investigation for trauma, FAST. But FAST is the most useless investigation available on planet. Let me tell you, FAST is the most useless investigation available on planet. I'm saying this on YouTube because everyone should know this. Before you are teaching this, before you are amalgamating this in your concept that FAST is fast and fast, try to understand what is FAST. FAST is the most useless investigation. What do we do in FAST here? What is that? Remember, FAST is not equivalent to ultrasonographic evaluation. FAST is an investigation where you do a quick assessment of 3 peritoneal pouches. What is that? HRP, SRP and pouch of Douglas You also look at the subxiphoid space for what? Cardiac tamponade. Yes or no? Yes. And then you say, you place the ultrasound probe and you see, if you see any collection here, you say that yes, if the collection is more than 200 cc, it is considered to be FAST positive. Since this patient is having hemoperitoneum and background of that patient is unstable, go for surgery. Yes or no? Now try to understand, but FAST doesn't evaluate your abdominal compartments, the abdominal organs. So you're not looking at the abdominal organs, you're quickly looking at the 3 pouches, HRP, SRP and what? Pouch of Douglas. Do you know that abdomen has 2 mega compartments? One is the peritoneal cavity and one is the retroperitoneal cavity. That means in FAST, you're only evaluating the 3 pouches of the peritoneal cavity. But if the FAST is negative, that doesn't rule out injury. Why? Because pancreatic injury, renal trauma, any retroperitoneal bleeds, they will not even present anything on FAST. Patient is unstable, you did a FAST after FAST, you did a DPL. And you said that patient is what? Conservatively, patient needs to be managed, and patient dies. And then people come to your hospital and then they do ransacking and they beat you, and then you say that people are not educated now, they are beating doctors. But say you should understand your concept. Your eyes will never see anything what your brain doesn't know, and you will be blindly a follower of fast. Fast is the most useless investigation. It is only brought into play. Try to understand the literature meaning fast. It is quick assessment in case of unstable blunt trauma where you are just in a mood to make a decision. Fast is not a diagnostic tool, it is a decision-making tool for abdominal trauma. Try to understand it's a decision-making tool. Shall I go for surgery or shall I continue with the conservative management? If you get a negative fast, that doesn't rule out what? The injury. Because retroperitoneal compartment is totally missed. Is that clear or no? Now I will ask you what is the first compartment, what is the sequencing of fast, and then we'll again come back to the schedule. Yes? What is the sequencing of the fast? What is the first quadrant that we examine? What is the first quadrant that we examine? Yes, this is fast. I hope you know what is fast. Focused, assessment, focus, assessment. Yes, focused assessment. What is, come on, tell me. Sonography for trauma. Sonography for trauma. There are many other forms also. Focus abdominal sonography for trauma. Yes, focus abdominal sonar for trauma. There are many, so don't rush behind that. Tell me the sequence. Like I always say, the answer is hidden in the question. Try to see. The first quadrant that we see is a subxiphoid. We look for tamponade. The second quadrant that we see is HRP. The second quadrant that we see is HRP. The third that we see is SRP. And the fourth is pouch of Douglas. So if you see the sequencing is something like this. Yes. Can you see? But say, can you see this in the answer? Don't mug up. Can you see this in the answer? Try to understand surgery is a subject of swag. Yes. If you don't have swag, you cannot be a surgeon. And can you, therefore, please don't write fast like this. Fast like this. S needs that swag. Is that clear or no? So can you see? The answer is written subxiphoid, HRP, SRP, pouch of Douglas. Yes or no? I can prove everything in this question. Try to understand. Try to use your surgical sense. You know, there's a difference between surgery and medicine. The people in medicine, they know everything. Everything. They are the most brilliant people on the planet, you know. But that's useless because most of the time, they cannot implement. Yes, they keep on making differential diagnosis. If you talk about the DM cardios, DM gastros, they are actually a modified version of surgeons because they are doing intervention. So without intervention, the medical field is like you have a Thakur of what? Thakur. So you can just keep on just having an overview and you can keep on making diagnosis. Now if you talk about surgeons, surgeons are the most moron category of people available on planet. We just know what to do, when to do. If you talk about knowledge, whatever we do, just see. Whenever we get a patient, we don't know anything, we say, let us open the abdomen. We will open the abdomen, see what needs to be removed, we will remove it. What we are understanding, we will keep it. And the only thing which a surgeon knows is resection and anastomosis. Yes. Do you know what is taught to us in surgery? The first thing and the last thing which is taught to us, that teach this kid how to do a resection and anastomosis. Because if he knows this, he can do any surgery. Is that clear? So when we get a patient in the abdomen, in the emergency, we come with all that swag, we put the hand over the abdomen, and then, you know, people are thinking, oh my God, the surgeon is having an MRI in his hand and he will tell what is the organ. And surgeon is thinking, yaar, kitni baar sir ne kaha? Every time sir used to say, study, 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 kuch padha hi nahi PG mein kya kare? And then he takes a deep breath after 2 minutes of doing this maneuver and saying, kholna padega, I have to operate. Because he knows once the patient is in my territory in the OT, I will examine, whatever I am understanding, I will keep, remaining I will remove that. So anyways, so we surgeons have a very blunt kind of brain, and that is why we rely on some tip and tricks. So can you see the first quadrant that we assess is the subxiphoid. Can you see subxiphoid? And what do you look in the subxiphoid? For tamponade? Yes. And then you do assessment of, then you do A for assessment of HRP, SRP and pouch of Douglas. And then next, just see everything is written. Then fluid more than how much? 200 cc. 200 cc. Yes, is considered to be what? Fast positive. Oh my God. Everything is there. Use your surgical sense to see the answer. So like we see the answer, we see the problem by seeing the patient. We should see the answers by taking the what? So this is known as associative memory. Is that clear? Let us come back. So FAST can only tell you about the collection of fluid in the peritoneal cavity. Hence, please, sincere request to you, don't say FAST is the first line investigation for abdominal trauma. You can say either CT or ultrasound. I will go for if CT facilities is not available. But ultrasound is not equal to FAST. In ultrasound, you look at the organs also, you look at the spaces also, you look at the paracolic gutters also, you appreciate everything. But in FAST, you're not doing that. Is that clear? So if the FAST is negative, you repeat a FAST. If it is negative again, what does that mean? This means that you are missing something, students. And what are you missing? You're missing a retroperitoneal injury. Now, retroperitoneal injuries, they will bleed. And if you bleed, what will fall? Hemoglobin will fall. When hemoglobin falls, yes, the changes are seen in the body. So what you do, if you think that FAST after FAST is negative and the patient is unstable, not improving, you start with serial hemoglobin estimation. Now, do you know hemoglobin? Suppose at the time of admission it was 12 and now it is 9. That means patient is losing blood and this is the time to take a call for surgery. But hemoglobin can often be deceptive because of hemoconcentration. Patient could have arrived with hemoglobin of 9. Patient could have arrived with hemoglobin of 9 and then after 2 hours you see it's 13. So how has this happened? Black magic? Something ominous? No, this is hemoconcentration. Hemoglobin can cheat you, but students, PCV cannot cheat you. So hemoglobin plus PCV estimation. Hemoglobin plus PCV estimation. Hemoglobin plus PCV estimation. Is that clear or no? Yes. Now how to interpret this? Yes. You see how the trend is. Yes. If it is falling, if hemoglobin and PCV is falling, this is a time to take a call for surgery. Yes. If this is constant, yes, you continue with what? Yes, continue conservative management. Continue conservative management. Tell me, is this basic approach to abdominal trauma, overview of abdominal trauma clear to you people or no? Just tell me, is this basic approach, are there any questions you can ask your questions here? Is this basic approach to abdominal trauma clear to you or no? Because along with this, I'll again take this one step ahead. I'll select 1 or 2 traumas and I'll discuss it for you. Yes. Okay. So now we move forward and we discuss a very special case, that is a case of gunshot injury. Try to understand a case of gunshot injury. Let us move forward. Let us quickly see how we approach a gunshot injury. Because recently we have seen questions on gunshot injury also. Let us evaluate gunshot injury. Yes. Now, if we talk about gunshot injury, one thing is clear. We know that gunshot injury, let the patient be stable or unstable, we have to go for what? Surgery. So surgery is the call. Yes or no? Surgery is the call. Yes. Now, what surgery needs to be done? What surgery needs to be done depends a lot on the patient's physiological status. Yes or no? So what surgery needs to be done depends upon the status of the patient. Yes or no? If the patient is unstable, you don't waste your time and you go for exploratory laparotomy. If the patient is unstable. Yes or no? If the patient is stable, yes or no? What to do now? If the patient is stable, now some people argue that said you should be going for CT now. Now try to understand CT scan. If you talk about CT scan, is approximately 60 to 70% sensitive for visceral injury. It's okay, it's very good sensitivity. But what about 30% of false negative reports? Because in this case, if you miss bowel injury, you miss the patient. Yes or no? So what is the most accurate form of diagnostic approach to these patients? So we cannot do a CT. Therefore, we want to avoid a scar also. Why? Because if you talk about exploratory laparotomy, it's a midline incision. Yes or no? It's a midline. Yes, from Ziffy to the pelvis. and you open the abdomen like a book. So it's like this. Can you see? It's like this. So you have opened the abdomen like this, and then you evaluate everything. Yes or no? So after you do this surgery, there will be post-surgical complication also, and there will be a whole line of scar also. Yes or no? Someone argued for this. That is why now we have, in this case, we will go for diagnostic laparoscopy. Diagnostic laparoscopy. Diagnostic laparoscopy. If you talk about diagnostic laparoscopy, what is the advantage of this? Bache, the entry into the abdomen is via 10 mm telescope. Even nowadays 5 mm telescope. Yes, 5 mm telescope you can do. So it's a very small telescope. It's only 5.5 mm incision that you make. And you go inside the abdomen, you examine all the spaces. And then if you see injury, you can do a laparoscopic repair there and there. If you are not confident, go do an exploratory laparotomy. Or if you see that injury is massive, you can go for an exploratory lap also. So diagnostic laparoscopy, and then you see the injury. If the injury is there, then you can always go for a repair. If there is no injury, yes, just close the wound, close the abdomen, finished. So observation now. Okay, let us move forward and let us see what is the difference. Now I will try to show you the difference, and then only you will realize why minimal invasive surgery is now a call in emergency also. Diagnostic laparoscopy is 100% sensitive, is 100% specific also. Is that clear? 100% sensitive, 100% specific, 100% accurate for any injury. I will show you how we make a midline incision, I will just quickly take you to some videos and I will show you how we make a midline incision. Yes. Okay. Try to see this video. And I'll just fast forward it. Yes. So I'm doing a minimal invasive. I'm doing a laparotomy. Just see the incision. How I make the incision. Just try to see this. So yes, see the markings of incision. It is subxiphoid. Yes. So from subxiphoid space, I'm going down. Can you see the incision? This is a classical what incision? This is a classical midline vertical incision. And then you stay a bit away. You don't cut the umbilicus. And can you see the incision? A 40 centimeter, 45 centimeter incision you have made over the abdomen. And you can imagine what will be the length of scar and post-operative complication. Now, if you talk about minimal access surgery, quickly I can demonstrate to you what is the point of entry. Now, this is a Scandinavian way of accessing the abdomen. You will make a very small nick. Can you see blade number 15? You will not be even able to appreciate the incision. This is so small. The incision is so small, and then you take a viris, which is hold it like a dart, and you will put it in. But simple, this much big incision, and then you inflate the abdomen. Once the abdomen is inflated, you will see once the abdomen is inflated. Now what you will do? You will enlarge incision. Can you see the size of incision? It is so small. Can you see the size of incision? It is so small, and hence done, finished. A port has been put in. And yes, with the corkscrew movement, you will put it, and you're gone inside the. Now let us take any surgery where we will appreciate the contents. Can you see if suppose I'm doing a diagnostic lab, can you see even the capillaries are visible? So if you are not a blind, you will not miss any injury. CT cannot detect that injuries to that precision. So now that is the call. Even the small capillary can be seen with this. Is that clear or no? Even if you are blind, your assistant will say, "Saab, dekho, there is injury. So it's a real-time view. You've gone inside the abdomen without opening the abdomen. And the second part is that you will have a magnified 25 times magnified view. Is that clear or no? So this is why now the laparoscopy has taken a charge even in the abdominal trauma cases. Is that clear? So this was the basic approach to abdominal trauma. Now I take generally abdominal trauma for at least 12 hours because trauma is not a chapter. It's a unit. It's a huge unit. So this is a simple. We are not having that much of time. So I just wanted to highlight the basic concept or basic approach to trauma. I will be getting you with many other approaches in the topics of what surgery. So I hope you liked it, and really again ask your friends not to miss these classes. Unacademy is really a very good platform, and it is an amalgamation of the best educators across the country. Take free classes. I say believe yourself. Take free classes. Use my code to access the free classes. Surgery Live is the code for YouTube subscribers. You use this code, unlock the free classes, feel the difference. We are not claiming the hierarchy that we have been this, we have been that. The things change, the generations change, no one is indispensable. So here we have the new team of the best educators, and take my words, this is committed to you. This team is 100% committed to you. So feel the experience. Do join an academy. This is again a time saving. You can take the classes according to your concept. This is the only platform where you can demand any class, and they will be obliged to do that, because here the educator will say, okay, I will do it for you. We don't have to take permission from the system. Please arrange for this class, and they will say we will not pay for this, they will not pay for that. We have the freedom, absolute freedom. Now student says, sir, I want to study this. I will say I will organize a special class just because of you. Even one student is important. Single student is important. So stay connected, stay tuned. We will be getting many more such cases. Tomorrow again we meet at 12:30. Till then, bye-bye. I hope you like the class.